Greetings and welcome to session 3 of the Lurie Children's Sleep Medicine Roundtable. My name is Chad Worley, Physician Liaison for the North and Northwest suburbs. And I'd like to thank you for joining us today. I am here with Dr. Ilya Khaytin, and he'll be talking to you today about neuromuscular disorder in sleep medicine. And I would just like to go ahead and remind you that this session is being recorded. And in addition, I would like to encourage you to ask questions as we go along. Feel free to type in those questions in the chat room, or at the end of the presentation, go ahead and raise your hand and we can go live and ask the questions then. So, but without any further ado, go ahead, Dr. Khaytin, and you can go ahead and start your presentation. Thank you so much.
So, my name is Ilya Khaytin. I am an attending physician here at Lurie Children's Hospital in Division of Sleep Medicine. And today I would like to talk about sleep in children with developmental delays. I don't have any financial disclosures. Today I will talk with you first about prevalence and frequency of sleep problems in children with developmental delay, especially children with autism spectrum disorder. I will talk to you how to approach children with sleep issues with developmental delays. I will discuss with you how we approach management those kids and what are some of the pitfalls. I will not concentrate much on how to manage obstructive sleep apnea or restless leg syndrome, because I think those will be covered in one of the other talks. So, sleep in children with developmental delay, there is a higher prevalence of insomnia and excessive daytime sleepiness in children with developmental delay and autism spectrum disorder. It is impossible to understand from a sleep medicine perspective that insomnia and excessive daytime sleepiness are two faces of the same coin. It is very common, especially as children progress into adolescence and adulthood, that they're starting to having more difficulty sleeping at night. And then what parents see is excessive daytime sleepiness. And so it kind of can be both insomnia and sleepiness can be a manifestation of the same problem. Children with developmental delay have more parasomnias, which are sleepwalking, sleep talking, bedwetting, etc. Those problems can persist into adulthood, results in worse functioning, and of course can cause parental stress and family stress. Different disorders have different problems. Children with Down syndrome have up to 80% have obstructive sleep apnea due to more flappy airways due to relative obesity. As you know, children with Down syndrome usually somewhat stubbier, and so they have a different growth curve scales because when placed on a typically growing child scale, their BMI looks higher. Children with Down syndrome often have excessive daytime sleepiness. They often have problems with sleep maintenance. Up to 86% of children with autism have sleep problems, especially insomnia and excessive sleepiness. But also due to diet problems, they often have restless leg syndrome problems. And there is some research that the structure of their sleep is somewhat altered. Children with Angelman syndrome have high prevalence of insomnia and sleep problems, which actually improves with age. Children with Prader-Willi syndrome have a lot of excessive daytime sleepiness. They have a significant amount of obstructive apnea, but they can also have quite often central apnea. So they often have mixed obstructive and central apneas. And again, they can have structure of sleep abnormalities. They are the REM behavioral disorders where a child is not completely paralyzed during REM sleep, rapid eye movement sleep, is more prevalent. In adults, it is an ominous sign of Parkinson's or Lewy body dementia, but in children, it does not carry the same scary problems, although in some people, REM behavioral disorders can be harbingers of excessive daytime sleepiness disorders, such as narcolepsy. Again, the pathophysiology is fairly complex. So one of the ways that we figure out if a child has sleep problems is ask questionnaires. One of the questionnaires which is most commonly used in research is Children's Sleep Habits Questionnaire. It's a 45 questionnaire, out of which 33 are scored on a scale from 1 rarely to 3 usually. It is liked by researchers questionnaire because not only it's well validated, but parts of it can be broken out, and they are also validated. So it is possible not only to determine whether children have sleep issues, but what sleep issues they have, all based on the same questionnaire. So using this questionnaire, a group of researchers have compared children with autism spectrum disorder with children with developmental delays, other developmental delays, which some of whom have autism spectrum disorder, some of whom did not have autism spectrum disorder, and compared them to population. And they looked at total score of 41, which is validated to indicate that the child has sleep issues, and total score of 48, which is more rigorous, rigorously indicating that there are some sleep issues. And as you can see, children with autism, with and without developmental delays, have higher percentage of children reporting sleep issues than children with developmental delay without autism or general population. In fact, adjusted odds ratio of a child with autism with developmental delays would be up to 2 times higher than the child with autism would be have sleep problems, while the children without developmental delays. Without autism, I apologize. And autism versus a general population, children up to 2.37 times more likely to have sleep problems. So autism is a very powerful predictor of sleep issues in our children. So most commonly reported problems are bedtime resistance, a difficulty of going to sleep, sleeping too little, waking in the middle of the night, inability to fall asleep without parents present, and inability to sleep in a child's own room. The problems, the cause of those problems is very, very broad. and not always entirely known. Some of the proposed mechanisms is dysregulation of circadian rhythm, abnormal secretion, and timing of melatonin. Many children have behavioral issues spilling out into behavioral insomnia of childhood. Many of them have comorbidities of anxiety, depression, oppositional defiant disorders, which again spill into difficulty of getting a child to sleep. Many of our children with autism and developmental delays are on other medications such as stimulants, SSRIs, mood stabilizers, all of which can disrupt sleep or disrupt falling to sleep. And again, we should never forget about other medical issues. Children with developmental delay, children with autism often have other comorbid medical issues which can very easily spill into sleep. So every child with autism, every child with developmental delay needs to be assessed for insomnia. If the child does have insomnia, we need to flesh out medical issues such as gastrointestinal problems, such as seizures, obstructive sleep apnea, asthma, pain, eczema, nutritional problems, low iron intake, which can cause restless leg syndrome. So find any medical issues which may contribute to child's difficulty keeping sleep. We also need to look very carefully at the bedtime routine, sleep habits, and provide education about sleep habits and bedtime routine. And with that, we need to meet regularly with the children to see how are we addressing all of those issues and see if we are making impact on child's insomnia. So the American Academy of Neurology says that every physician who would like to impact sleep in children with autism should make an assessment of all coexisting conditions, should review medications, should look at what are the contributors to the sleep issues in the children, and should provide education about how sleep should be about sleep habits. Okay, so the way we assess, we can use questionnaire, we can use the formal questionnaire like CSHQ, or some modifications of it. There are other type of questionnaires which have fewer questions. In fact, one of the simplest way and fastest way to assess, which is very often used in pediatric clinics, is Bear's questionnaire: bedtime, excessive daytime sleepiness, awakening during the night, regularity of sleep, and snoring. So answering yes to any of those questions will prompt that this child has some sleep problems. So once we know that the child has sleep issues, we need to establish good time routine. Bedroom should be dark. The routine should start not too early. It is bad if bedtime routine is excruciatingly long. Our children should not go through 2 hours of preparing for bed. Children, especially children with developmental delays, they don't necessarily understand what is going on and how to deal with it. And so having a schedule, having a routine organizes their evening, tells them what will happen next. We're brushing our teeth, therefore next we will be changing into PJs. We're changing into PJs, therefore next thing we will be reading. And so that cues the child into what will happen next and helps the child to fall asleep. Electronics should not be part of sleep. As a sleep physician, I strongly believe that people who fall asleep with TV sleep not thanks to TV, but despite TV. Bright light suppresses secretion of melatonin in our brain, and therefore falling asleep with TV is like falling asleep while sipping a little bit of coffee. So we need to stop electronics and teach our children to stop electronics. Children should go to bed regularly. Weekend is not a reason to go to bed 3 hours later. And I usually talk to my parents that switching time is like switching time zone. So if a child goes to bed at 10 o'clock on Thursday and at 1 o'clock in the morning on Friday, it is equivalent to child traveling to San Francisco on Friday, spending weekend in San Francisco, and then returning back to Chicago on Sunday. That's an impossible schedule from the biological perspective. And so our sleep schedule must be regular. We need to teach our children to fall asleep on their own. Otherwise, parents will always think that their children are not sleeping. Waking up between 4 and 6 times per night is normal. We all do it. The difference is we all fall asleep on our own. And so if the child asks the parent to help him to fall asleep 6 times per night, the parent will be in our offices telling that the child has insomnia. All the children should avoid naps. One of the excellent ways to teach our children on how to sleep is provided by an organization which is called Autism Speaks, and it's just autismspeaks.org, and they have a lot of resources. They have graphic schedules. A lot of children like graphic schedules on when we are putting the PJs, what will happen next. So they provide handouts to children, how to, not to children, but to parents, to how to teach their children to sleep more effectively, how to fall asleep more effectively. And it is important to understand that just giving fit-all handouts don't usually work. It is important to do custom assessment of problems. If a child needs a bottle of milk to fall asleep, we need to figure out a pathway for this family, how to teach a child not to have a bottle of milk, because child cannot get a bottle of milk independently in the middle of the night. If a child needs to be rocked to sleep, we need to figure out how to stop that practice, because again, child cannot rock himself in the middle of the night, and we all wake up to 6 times per night as a part of our regular sleep cycle. And so we need to figure out with particular family how we can gradually move the parent out of the bedroom. Crying out works. However, crying out works on very few parents, and those parents will likely not come to us because it requires a lot of stamina on the part of the parent, because usually crying out goes from bad to worse to worse to worse to worse to worse before it's starting to get better. And so it requires quite a few days, sometimes quite a few weeks of suffering through the child's cry. And very few parents are that strong to be able to know that the child is safe and not to go for the rescue. And so more sparing and more custom ways to teach our children how to fall asleep independently often works better. In addition to behavioral therapy, we should suggest the use of melatonin. We should suggest use of melatonin about an hour prior bedtime. Now, melatonin has a bi-lobe action, and low doses between 1 and 3 milligrams, it is an excellent circadian clock regulator. In high doses, over 10 milligrams, it is a very poor sedative. So melatonin never becomes very strong sedative. We make it so we are not sloth. Therefore, melatonin cannot be very powerful sedative. But in very small doses, it's a clock regulator, and that's what we use it for. We help our children fall asleep. We're not knocking them out of sleep. And parents need to know that should be the expectation. Expectation should not be that the child will be knocked out 1 hour after taking melatonin. The expectation should be that the child should have easier time falling asleep an hour after taking melatonin. Considering that it is considered to be a supplement, it is better to prescribe it than to just send them to take it off the shelf. Sometimes purity is a little better. We should be aware of alternative treatments, weighted blankets, special mattresses, aromatherapy. The evidence is very poor that they do anything. However, the risk of using them is very low. So even though evidence is lacking, we should still discuss that, because some children might actually do better with weighted blankets. The clinic is abound with parents who report that weighted blanket helped them a lot. But formal studies did not find so far significant evidence that weighted blankets are particularly miracle of helping children to fall asleep. It is important to also consider other medications with the child taking. Carbamazepine, gabapentin, Topamax, valproic acid, all sedating. Lamotrigine is not. It is arousing. Risperidone was FDA approved to treat irritability and aggression in children. So in children who fight sleep, sometimes risperidone is actually what they need. And when I say fight, I have patients who literally punch parents for attempting to put them to sleep. So risperidone, behavioral pediatrics is very important. Mirtazapine and trazodone are very sedating. Doxepin is very sedating and has a long half-life. Guanfacine, clonidine are often used in ADHD to help children fall asleep. Light therapy is very effective to increase alertness. Children should not be sitting in the dark bedroom in the morning. They woke up, shades open, they are blasted with bright light. If they are very sedated during the day, if they have excessive daytime sleepiness during the day, exercising, light therapy during the day can also be helpful. However, we do need to remember that sedating medication may have paradoxical reactions. And that is, again, because children don't understand what is being sleepy. We all have a level of comfort in terms of our alertness. And as our alertness goes down, we too become hyperactive. Remember the time that any of us were driving and we could not stop. We took stimulant, coffee, in order to stay awake, or we turned up the music and started to dance in front of our wheel. All of this, if looked from outside, aside of hyperactivity, we try to keep our level of alertness at the comfort level. And so that's what children do when they start to get sedated. Some of them start to become paradoxically hyper in order to overcome that sleepiness. And so sometimes just hyperactivity means that the dose needs to be increased. On the other hand, there are some medications which do have abnormal reactions. For instance, gabapentin may cause aggression. I had a patient a couple years ago whom I started to low dose gabapentin, and he tried to kill his own dog. So we need to be aware of the side effects of our medications. Talk to parents that when we're giving sedating medication, the expected effect is sedation. Everything else needs to be discussed with us. So, in conclusion, we need to address in the children with developmental delay, we need to address behavioral therapies for insomnia, melatonin, light therapy, addressing coexisting conditions. We need to address obstructive sleep apnea, periodic limb movement disorders, etc. And with that, I would like to open the floor to questions. Thank you. Hello?
Sorry about that. I'm having a little bit of a glitch in my system, but you should be able to hear me. So if you'd like to ask Dr. Khaytin any questions, feel free to unmute yourself, and we'll go ahead and answer your questions. We'll give you a minute to type those up. Okay, so it doesn't look like we have any questions right now for you, but I just wanted to go ahead and thank everybody for joining us today. This was a great talk. And again, this is being recorded. So I know some of you today jumped on a little bit late. So I will be sending you a link to view this message or view this recording today. And then you can get the full details on it when you can. I want to remind you that we are having there's one question just did come in. I'm sorry. What's the best way to refer into sleep medicine right now? And are you doing any telemedicine visits?
Yes, all of us do telemedicine visits. Sleep medicine is very well suited for telemedicine visits. And from what I know, you just send a referral to sleep medicine programs. Irina, if you are still online, is this correct? So do we just send a referral to Lurie Sleep Center?
Yes, you are correct. And if you'd like to fax us your notes and a referral, we would greatly appreciate it. The fax number is 312-227-9444. 888-952. If you have access to Epic, you can also send us a quick message. We can always facilitate, or we'll try our best to facilitate the visit.
Excellent, thank you. And then as you see here on your screen, Dr. Khaytin's phone number. We also have an email address. There is a Epic in-basket as well as Rapid Connect. And of course, remind you to use Lurie MD if you have some immediate questions as well. So again, I'd like to thank you all for joining us today. And a reminder that this afternoon, Dr. Dang will be talking about parasomnia at 12:30 for our session 4. And another reminder, I noticed a lot of new registrations today for the event. You don't have to keep re-registering to each one of our sessions. You could use the same links to keep joining. So no need to have to re-register. So, but with that, I'd just like to thank you all for joining us this morning. And I look forward to seeing you this afternoon at 12:30 for session 4. Have a great day, everybody.
Fantastic talk. Thank you.
Thank you.
Bye. Thank you.